So welcome. We got distal radius and forearm injuries tonight. We're going to talk about a ton of interesting cases. And here we go. Just a reminder, AO link. We're about listening, integrating, networking, and knowledge, and we appreciate you joining us. As you build that foundational orthopedic trauma knowledge, we appreciate the support, as always, from Dr. Mark Lee, our AO North America president, and our AO North America chair, Dr. Kapatkin. And then our sage is here with us tonight, Dr. Aker. We're always happy he can join us for these discussions. Phil's on the Q&A, so don't hesitate to ask a bunch of questions while we're going through things here. And we've got two great faculty with us to go over some distal radius and forearm fractures, getting both a hand surgery perspective and a trauma surgery perspective. Let's start with you, Kevin. Tell us about where you are, and then maybe how you decided to go into hand surgery.
Thanks, Taylor. My name is Kevin Malone. I'm the chief of hand and upper extremity surgery at University Hospitals Cleveland Medical Center, affiliated with Case Western Reserve University. And I've been in practice here now. I think this is my 19th year. Hand surgery for me was, it's great. I get to sit down while I operate. And I have a few inpatients, so not a lot of rounding. So, good lifestyle. But for me, it was the mentors. I did my residency at University of Cincinnati with Peter Stern, who is one of the all-time greats in any specialty, but certainly a world-class hand surgeon, and that was my first exposure. Thanks for having
me. Yeah, for sure. Nate, why don't you take us through where you are and how you decided to do trauma?
Yeah, so I'm in my second year of practice in private practice outside of Seattle in Washington. And I did trauma because I liked the variety. I wanted to go everywhere in the body and do everything and get a little bit of having to think on my feet and, figure things out as we go and problem solve.
Perfect. Well, we're going to solve some problems tonight. So let's dive in. This is just a reminder where we've been and where we're going. Quick plug for AO Milestones. I know a lot of people are working on chapters for this, so more and more educational content coming out from AO in that regard. Don't hesitate to ask your questions. Use that Q&A box. Don't forget to watch on YouTube later to hash out some of those details that we may be going a little bit quickly through, but don't forget to reference that in prior lectures there. And in terms of prior lectures, last month before we did the interview session, we did talk about spine injuries. And so one of the things that Dr. Weiner and Dr. Showery talked to us about was really developing a systematic approach to the spine patient. And that includes your history and physical exam, but also your imaging review, because those CT scans can be tricky. And don't hesitate to load the boat or bump it up, really, if you need to when you're a junior resident taking those calls. Also, make sure you look at that CT scan closely. Look for these really fine details that reveal instability, things like we show here, where there's some of the splaying of the anterior vertebral bodies and certain fracture patterns. And then also just a quick reminder about ankylosis in the spine. That means the spine is essentially fused and is like a long bone, and those are essentially injuries that are almost always fixed. And then you don't want to miss emergencies, things like a cauda equina syndrome, where you have saddle anesthesia and bladder and bowel dysfunction. And these are things that you can really make a big difference in the patient's outcomes with. But tonight we're talking about distal radius and forearm, and so we're going to cover some really interesting cases. The objectives tonight, we really want you to be able to evaluate distal radius and forearm fractures, and then think about how you're going to reduce those in the ER and in a effective manner. So you're going to have to really think about what system you're in and then build a process by which you can get those done quick, and then identify injuries that necessitate surgery as well. And so when you see these patients in the ER, you're really going to take a really good history, and there are certain things that you want to get out of that. Obviously, age is an important factor, but also the patient's activity level. Are they a pianist, a concert pianist? That may affect what you do for them. Or are they just like a grandma? Maybe they're like a breakdancing grandma like this lady, but all those things may factor in how you treat their injury. Also, their hand dominance is important, and then any neurologic symptoms, because like we talked about before on the hand surgery talk about hand consults, we're always going to be worried about acute carpal tunnel. Anything you guys might add to the history and physical exam that you don't like trainees or med students to miss?
I think you covered the major ones here. The other things, just to not neglect would be certainly mechanism of injury, whether this is a high energy or low energy injury, and then underlying, significant medical comorbidities, diabetes, kidney disease, etc. But the ones you got listed there are certainly very important to not miss.
Those are great points for sure, because those can affect outcomes as well. And so when you see the patient, you're also going to do a really thorough physical exam and get a good neurologic exam, like we said, focusing on some of those median nerve symptoms, but also a thorough neurovascular exam with regard to radial and ulnar pulses, other testing that you may do, looking for open wounds like the one here. You don't really have to look very hard for this one, but then sometimes you want to also be aware of additional injuries that may affect your treatment plan. And we'll talk about some cases where that may be the case. Additionally, you may want to get x-rays of the joint above and below to see if there are other associated injuries, and we'll show you why in some of these cases as well. Anything you'd add there, Nate?
I think you covered the majority of it. I think it's worth examining carefully around the area that's injured in the hand or in the elbow for a distal radius fracture because other injuries can occur.
Yeah, I think, taking off splints, unwrapping your presence, if you will.
Taylor, I would just submit one more suggestion that as
Please do.
orthopedic house staff, when it comes to the physical exam, that they need to turn the page and understand that writing Wiggles fingers isn't quite enough. You know what I mean? I continue to see that with house staff, and I mean I think MS4s medical students should start to become familiar with the nuances and the details of the exams and what deficits, what nerve palsies might present with what lack of sensation or motor in different parts of the hand.
Yeah, that's a great point because it may be important in terms of is there an injury to a tendon, an extensor tendon, a flexor tendon that may impact how they move the fingers, and maybe they wiggle some, but not all. Hard to know. But that's an excellent point for sure. Nate, why don't you take us through the pathoanatomy? So, like the bony anatomy relevant to distal radius fractures.
Yeah, when the distal radius breaks, I think it's important, especially as we're starting to think about putting it back together, to pay attention to what parts are there and what we need to reconstruct. And so, I think A here is the radial styloid, and we know that that has the portion of the distal radius that's articulating with the scaphoid, and that often can end up being a separate fragment from the lunate facet, which articulates with the lunate in the hand. And in more complex injuries, that more ulnar side of that distal radius can break into dorsal and palmar parts, and those can be important to bring back together to restore the stability. As we see here, the ligaments attached to these different parts, and in particular, that short radial lunate ligament there that's attaching to that lunate facet is particularly important for maintaining stability. And we often see an ulnar styloid fracture as well with these, and it's important to remember that the TFCC or the radial ulnar ligaments are attaching, and that can contribute to stability of that distal radial ulnar joint.
How would you explain the TFCC to a med student, Kevin? Like what's a good way to describe that?
Well, the way I explain it to my patients is probably pretty appropriate as well, is that this is like a disc in your back or a meniscus in your knee. It's a shock absorber. It helps transfer the loads from your hand to your forearm, but it also has strong components in maintaining stability of the radial ulnar joint. And commonly injured with distal radius fractures with associated ulnar styloid fractures. Fortunately, most of them don't need treatment when they're associated with distal radius fractures. If you get a good management of your radius fracture, whether operatively or non-operatively, good alignment, it's not common that patients are going to need secondary procedures for the distal radial ulnar joint. But as we'll get into later in this session, patients with unstable distal radial ulnar joints, even after fixation of the distal radius or the radial fracture, that can't be ignored. and we'll talk about that a little bit later on.
Yeah, that's a great point. I might use that when I talk to patients. So there's also some other structures around the wrist, as we well know, and so we want to make sure you're familiar with and you review these structures. So you can see here the radial artery and the ulnar artery are the important vascular structures, and then you have the median nerve and the ulnar nerve highlighted here as well. And just being aware of the contents of the carpal tunnel, that's probably something that somebody may ask you on a rotation. Pretty low-hanging fruit to get an easy question answered here, and you can see those are the 4 FDS and 4 FDP tendons, as well as the median nerve and the flexor pollicis longus as well. Those are all within the carpal tunnel there, and so you want to be aware of those. Kevin, will you take us through some of the parameters that you're looking at when you're looking at X-rays of distal radius, and maybe like how what's a good way to try to remember them?
Well, certainly in order to realize, how displaced or deformed your fracture is, you have to know what normal is. And so these images, represent what we call normal. The radial inclination on the image on the left, which is a sort of a PA representation of the wrist, is a measure of the angle of the articular surface of the distal radius relative to perpendicular of the longitudinal axis of the radial shaft, and that should be roughly 23 degrees, excuse me. Whereas radial height is also similar to radial inclination. That is the difference in height between the radial styloid and then the lowest part of the radius, which is the lunate facet of the radius. And so if your inclination is diminished, your radial height will also be diminished. Ulnar variance is a measure of the terminal length of the radius relative to the ulna, as demonstrated here, and normal is equal to plus or minus 2 millimeters. And then on the lateral image, the palmar tilt is a line from the dorsal rim of the radius to the volar rim of the radius relative to the perpendicular of the radial shaft. And then that 70-degree angle is the volar teardrop angle. And that is a measure of this, the line supporting or under the lunate facet of the distal radius relative to the perpendicular of the radius. And as we start to look at some of these x-rays of injuries, you'll see some of these abnormal or what's abnormal. And so when we start to think about what's unacceptable, what needs a reduction, or perhaps what needs surgical intervention, would be these numbers here: radial inclination less than 10 degrees, radial shortening greater than 5 millimeters, volar tilt greater than 20, or dorsal tilt greater than 10 degrees, and then articular incongruity or step off greater than 2 millimeters. And as you start to look at x-rays more and more as you get through training, you'll see all of these put into play.
So yeah, that brings us to our first case. This is a 65-year-old guy. He fell from a slight height. This is a consult that I think you saw, Nate. And so your first bet with him is what when you see him, like as you talk to him?
When I saw this man, he's an active 65-year-old avid skier who fell off of a ladder while doing work. And the first thing I did when I saw him was just a good exam, and he didn't have an open injury, and all his nerves and vessels were functioning. And so we talked about putting this back into an appropriate position for him without surgery, and putting on a splint to get him stabilized so that we could then make further plans.
Yeah, I think that's always a good place to start. You don't just jump straight to surgery in most of these. And so when you see him, you really want to think about how you're going to do that closed reduction. And so we're going to take you through a little bit of that here. And I want you to think about how you adapt that to your own institution, because every institution is a little bit different. You can see here, this looks like a medieval torture device, I'm not going to lie, but there are more sleek looking finger traps, if you will, that help you get a reduction. And so I was a finger trap guy. I don't know about you guys. Phil, I bet you just went down and hogged on them. I bet you were too busy at Vandy.
I just went for it,
Yeah, you're too busy at Vandy. I mean, I was at Dartmouth. We had some time to take our time, put them in the traps, kind of be a little more finessed with it.
It is nice if you see them, you numb them up, you put them in traps, you go do something else for 5, 10 minutes, things kind of loosen up a little bit. It's a nice way if you don't have an assistant too, you can splint them in the traps too. So it's a nice augment, you know.
Yeah, you can see here, and some of the pictures don't project well. This is an old video from the AO, and so I'm gonna play it because I like this video. It's kind of funny. This guy's expression. You got to watch his expression as he goes through this. He just gets that look on his face of like some abject terror there or something. I thought it was pretty comical. But as you see here, he's putting a patient in the traps there. And then after that, he does do this hematoma block, which is you use a needle to insert lidocaine into the fracture site. And you can do that under fluoroscopic guidance as well. And that usually provides pretty good analgesia while you do that reduction maneuver. And so, it's just too good there. Um, but then from there, then you actually have to do the reduction maneuver itself. One of the important points of doing your hematoma block, when you put that needle in, even though you're looking at it under fluoro, you want to get a good rush of blood back there to know you're in that fracture hematoma. And then you also don't want to meet a lot of resistance because you should be entering a pretty big space there. And so after that, after you've done gotten the tissues relaxed and you've numbed them up, then you can do your reduction maneuver. And so how do you tell your residents to go about doing the maneuver itself, Kevin?
Well, so these pictures are from operating room, obviously, where we don't necessarily need finger traps because we have a patient that's under general anesthesia and paralyzed. But just to echo what Phil said on the last slide, traction and counter traction on the upper arm, really to let the forearm muscles relax, are really key to get this fracture reduced in the emergency room. So I do like the finger trap apparatus. Occasionally we'll have a patient that comes into clinic with a fracture that we want to try to reduce, and I don't have the finger traps and we don't have the IV meds, and so it's a little harder to do it in that setting. But with any sort of fracture deformity and reduction anywhere in the body, you're going to exaggerate the deformity first. So what we're seeing on that top images, and then a little bit of longitudinal traction, and then we want to volarly translate. This is for a dorsally displaced fracture, which is the most common fracture pattern. So exaggerate the deformity, a little bit of longitudinal traction, and then volar translation, not flexion of the fracture. And you certainly don't want to immobilize a wrist inflection as well for carpal tunnel syndrome purposes that we'll discuss later. If it's a fracture that's displaced in a volar direction, then the reduction is going to be a little bit different. A lot of the volarly unstable fractures are much more inherently unstable and ones that are going to need more likely to need surgery, whereas some of these dorsally translated or angulated fractures, in many situations, adequate reduction and careful monitoring may be amenable to non-operative management.
Yeah, those are excellent points. Certainly with those volar displaced fractures, often you're just splinting them in a neutral position almost, and that's why the traps become so nice because it's already holding them there. And then another important point that you made about not flexion, I think sometimes the error is flexing through the wrist a little bit as you're trying to do what's called a 3-point mold as you apply the splint. Any tips for splint making, application, all that stuff?
Well, I think we want controlling the forearm rotation is certainly important, and putting them into a sugar tong splint as demonstrated here. Although I would certainly recommend putting some padding on the skin underneath the splint. But by putting them into a sugar tong splint, you really limit the patient from going into full elbow extension, which prevents their hand from hanging down in a dependent position. So it really would help with minimizing swelling. You want to make sure, as is relatively well shown on these images on the bottom right, that the splint does not extend past the MP joints. These patients should be able to nearly fully flex their MP joints and certainly their IP joints, as that will help prevent any significant stiffness or swelling, after treatment or after surgery.
Yeah, definitely good points where I certainly had the experience myself being in conference in the morning, showing some of these and be like, oh, that's splint. Is that past the MCPs there? You might have to go cut that back. And then you got to go back. Yeah. And so going back to that first case that you saw, Nate, these are his x-rays in the splint. Looks pretty darn good. You still got it. Which
Yeah,
of
I mean,
the
I think we got him back into a good position, but now the question is he going to stay there? I think that's
yeah.
always the concern with these.
Yeah, so he's there, and I don't think he meets any of these criteria.
Not at the moment, I would say.
Yeah.
Yeah.
So maybe op, maybe non-op, TBD.
Yeah, I think that's one where you can talk to him about, well, given his activity level, does he want surgery or does he not? We can talk a little bit about what factors might contribute to predicting whether he's going to be unstable. But you can also watch him closely and bring him back in a week for another X-ray and see how he does.
For sure. This is a patient that didn't have surgery. And Kevin, maybe you can talk to us a little bit how you talk to these patients about not having surgery and what sort of expectations they can have with these injuries.
Sure, and a lot of it depends on patient age and activity level that we sort of hit on in that first slide of the history. And we have ample supporting evidence in our literature that suggests the older, lower demand patient can tolerate fairly significant deformity. And so, as you look at these X-rays of a healed fracture with loss of radial height, ulnar variance is now positive. The ulna is longer than the radius. The inclination is off. On the lateral, the volar tilt is pretty good. And you'd look at that X-ray and say that looks pretty ugly. And then you look at what her wrist does, and while she certainly has some loss of wrist extension, her other motion parameters are pretty symmetric bilaterally and very good functional outcome. Happy patient. So not all fractures need surgery. And we're certainly less aggressive with operative management or recommendations of operative management in older patients because we know they can do so well with deformity. And in addition, there's a much higher complication profile, both from anesthesia, but the surgery itself because of their poorer bone quality with surgery for these patients.
And to top it off, she's got pretty good style. I mean, that's a pretty sick sweater, not gonna lie.
Back to breakdancing.
Yeah, exactly. Nate, talk to me about how LaFontaine may apply to your guy, though. So, and talk to us a little bit about what this criteria is used for in your practice.
So this is a landmark study that gets quoted a lot, and I think is important to be aware of, where these authors looked at whether they could predict which fractures would end up needing surgery if they reduced them and put them in an adequate splint. And what they found was that when essentially the degree of displacement was high, when the fracture was complex, when it was comminuted, that is, when it's tilted back more than 20 degrees, it's shortened more than half a centimeter, there's comminution on that dorsal side, and the articular surface is comminuted as well. When there's an associated ulna fracture, which we remember destabilizes that distal radial ulnar joint. And when they're older, probably suggestive of poor bone quality. They're all those things are more likely to contribute to them displacing with non-operative management. And so if you think back to the first patient we talked about, he actually meets almost all or all of these criteria. If you look back at his injury films, even though his splinted film looked pretty good. And so he might be somebody that you might consider surgery for. Now, I
Yeah.
would say that, LaFontaine may not have been, not all these criteria have been fully reproduced, but I think the gist is that more displacement, more energy, more complexity, higher risk of redisplacement.
Yeah, I think it's a common article that's discussed, and so it's like less than 3 pages. So if you want to read it and look good when they ask you about it, it's pretty easy to do. You don't have much of an excuse there. It's like nice and to the point. All right, so far we talked about a bunch of stuff, but in particular, as far as your H&P goes, you got to understand occupation, activity level, hand dominance, and get a thorough nerve exam. Also be aware of the contents of the carpal tunnel, as well as the risk for acute carpal tunnel syndrome. Think about some of that bony and ligamentous anatomy. We did talk about that in the ankle and how it's sort of similarly relevant and how it may destabilize the ankle. And then how are you going to do your closed reductions when you start seeing them on your own, building a process that is smooth, efficient, and allows you to see like 50 consults like they do at Vandy. And then also think about memorizing those LaFontaine criteria and read the short article. Phil, any questions?
Yeah, I think Justin asked a good one. Maybe I'll throw it to Acre. Is there a time when, out from injury, that closed reduction of a distal radius is no longer a good idea or feasible, if they come in to clinic, a week, 2 week, 3 weeks late? Is there a time where you think it shouldn't be attempted?
Yeah, I mean, as was mentioned earlier, your clinic has to be set up with the right equipment. Do you have IV stands and weights? And we used to just use a Curlex. We weren't high tech with finger traps. Just wrap a Curlex around some fingers and make our own little traps. Um, but I'd say within a couple days, they're still going to move. It's still acceptable. Surely, the younger patients get, the stickier and the more challenging it gets to mobilize a fracture. uh, Even early, even within a couple days, things can get pretty sticky and challenging to move. Um, but I think that the most surprising thing for me, as was mentioned, some of these distal radius fractures that you give it the college try, you reduce them in 70, 80, 90-year-olds, they come back to the clinic and they've displaced, they don't look so good. It's amazing to me that they heal malunited and how functionally you really wouldn't even know it. You wouldn't know it. They just function so well. They don't complain. And back when I was a resident, we were operating on a lot of distal radius fractures in older folks, because the volar locking plates had just come out and they were fancy. Now we're realizing that we probably didn't need to do a lot of those surgeries. So that's a long answer, but I'd say anything beyond a couple days, it's probably not worth trying to torture the patient.
Yeah, I know the hematoma block once the hematoma gets a little bit more congealed, it becomes a little bit more challenging, a little bit more poking, a little bit less flash of blood. So if you get to those acutely, it's a pretty nice procedure, pretty easy. But the other one, Taylor, I just want to bring up that somebody just asked, I think it's a great question, time to show off. When it comes to giving report on nerve exams, how can we as students cover all the bases while being concise? It's a great question because you don't necessarily need to go through, each finger 2-point discrimination. But if you use the injury to guide a directed exam, let's say it's a displaced distal radius, and you report a thorough median nerve exam, then you're demonstrating to who you're presenting, I know what nerve is at risk. I also know how to do a detailed exam without just going way over the top and testing detailed radial nerve exam on a distal radius, if that makes sense. Kevin, anything to add?
No, I think that's a great point, but you also, don't want to forget to examine them after reduction as well. Or after a
Mm.
cast goes on, a cast that's gone too tight, or someone who is immobilized with wrist flexion, which is going to increase the pressure on their median nerve. So, doing a reduction is not necessarily a benign process, and you want to make sure that you're doing everything in a soft tissue friendly way. And you have to document all of this. And just as we've started talking a little bit about operative and non-operative fractures. In many cases, operating the patient is less labor intensive. To treat a patient non-operatively, to watch them and make sure they don't displace, really takes a lot of office visits. It takes a lot of time, and I see these patients, weekly for 3 or 4 weeks with X-rays, making sure their cast is appropriately fitting, making sure their fracture is not displacing. Whereas, if you see the patient the first day and say, "Oh, we're just going to operate on you," well, you get them on their schedule later in the week, and then, in many cases, I'll see you in a couple of weeks, and I'll see you a month later, and you're good to go. But you got to do the right thing for these patients, and probably more of the fractures that I see are treated non-operatively than ones that I recommend surgery on.
Excellent points for sure. Nate, this is another patient. This one's definitely younger. The X-ray looks a little bit similar to the other one, but um, take us through this case.
Yeah, so this is a 31-year-old man. Again, he's fallen off of a roof while working, and he came in with this distal radius fracture, dorsal comminution, a little bit of shortening there. But I think it was important in his case to also note that he has a spine fracture as well. And so he's going to be getting surgery for this fracture, and he's going to have some restrictions on his mobilization. He's going to have difficulty mobilizing, and he may not be so comfortable in a sugar tongue splint trying to use a walker. So that's one of the things that might push you to consider surgery. And in this active 31-year-old, he wanted surgery, and so that's what we did for him. And we put on one of those fancy volar locking plates that Dr. Aker was mentioning.
And so in this case, how is this plate functioning, if you will? We've talked a little bit before about buttressing periarticular fractures or type B type fractures. In this case, it was going the other way though. So how is this mechanically working?
Yeah, if we wanted to buttress this fracture, that would be a dorsal plate that we would need. And in the setting of the dorsal comminution, I don't think we're going to get a good buttress effect there. So this is bridging that and holding it out in the right position.
Yeah, so commonly we will place volar locking plates are generally better tolerated, I would say, than many of the dorsal plates. And so commonly, even though it doesn't really work in the same way you might think as we have in the past, it does function well for the purposes that we're trying to accomplish. This is another case. Kevin, you sent us this case. Talk to us about how this one's a little bit different. Uh, Obviously, it's bilateral, but these x-rays look a lot different.
So this is a woman who had a fall down a stairs and, fortunately doesn't have the spine fracture or the femur fracture or hip fracture that some of these other patients might sustain. But bilateral wrist injuries are very challenging to take care of. You put a patient, even if they were both non-displaced, to put a patient in bilateral sugar tongue splints or bilateral short arm splints, that patient can't feed themselves. They can't really do anything for a significant amount of time. So having a bilateral injury may be an indication to do something for certainly both of them, or at least one. On the left side, you have the PA and lateral of a very minimally displaced, primarily extra-articular fracture. You got to love the IV still in the patient's hand on the X-ray, and then on the right one, you almost can't identify really any of the injured parts. This is you don't really need to know a lot of fracture classifications, but one that's pretty appropriate to all body parts is the Eastwood classification system. You guys are all probably too young for it, but the good, the bad, and the ugly. This is an Eastwood 3. This is an ugly one here.
I
And
like
with these
that.
higher, this is with an older patient and the osteoporotic bone, it doesn't require as much energy to produce a more significantly displaced unstable fracture pattern. And so here's how we treated this patient with the minimally displaced fracture. We did put a volar plate on her just so we could get her out of a cast faster so she could use her hand for activities of daily living. And then on the right one, this is a dorsal spanning bridge plate, which is basically an internal buried external fixator, where we can, get our length, get our relative alignment, and put this plate connecting the metacarpals to the radius. So we are removing all of the strain across that fracture so it will stay aligned. And then obviously that plate needs to be removed several months later after the fracture has consolidated. But in these really bad, very comminuted situations, this type of technique can be very helpful rather than trying to piece all of these pieces together, which can be an exercise in futility for sure.
Yeah, it's definitely a useful adjunct in some of these challenging cases. Um, it's definitely something I've seen become more commonly used. Nate, this is another high energy wrist fracture here, and I guess this one's also an Eastwood 3, I'd say.
I would say so. I'm learning that classification today as well, and I'll be using it in the future. Yeah, this man had a little bit higher energy involved in his injury. It was not just a fall, but he was in a motorcycle collision, and he has this left distal radius fracture you see on the left. He has a left proximal humerus fracture, and then he has this open right distal radius fracture that we'll focus on.
Yeah, and so this is, based on this X-ray, even if that wound is pretty small, my guess is you would call this a type 3 injury because of the amount of energy imparted and the likely underlying soft tissue degloving.
That's absolutely what I found. You know, in the operating room, we did a thorough debridement, and unfortunately, there was a lot of bone that was devitalized and had to be removed. And so this is our these are our films from postoperative day 0. He had too much bone loss to do a dorsal spanning plate. It wouldn't reach, and so we did an external fixator here. And you can see the cement that we put in to sort of hold things in place and plan to come back for a bone graft. And I was patting myself on the back for a decent first stage here. And then that afternoon, the next morning, he starts having more and more pain. And what do you think's going on, Taylor?
Yeah, I think you start to be worried about that person. You probably want to go see them, evaluate them, especially if the pain is getting worse, pain meds are going up. You got to start thinking about things like maybe a compartment syndrome or something like a carpal tunnel syndrome, like we had talked about before. And so I think assessing these patients as you start getting more calls about them is pretty important, especially one where it had this much energy imparted onto the wrist there.
Yeah, absolutely. You know, everybody's telling me, oh, his forearm compartments are soft. He doesn't have compartment syndrome, but he's sure is requiring a lot of pain medication. And so, of course, I go see him and find out that he has diminished sensation in that index finger, the middle finger, the thumb. He's starting to get some acute carpal tunnel syndrome. So we had to take him back for a carpal tunnel release, even though he didn't have any symptoms right after surgery.
Yeah. And so I think what I'd say for this case, just a quick plug, time to antibiotics is important and getting a thorough debridement. Um, and then is there any role for an acute or prophylactic carpal tunnel release? Any thoughts on that, Kevin?
Of course, yeah. So someone who has documented carpal tunnel syndrome symptoms, and it's not uncommon that you'll see a patient who, had carpal tunnel syndrome diagnosed preoperatively. We know these patients are going to get swollen after surgery, and so mild carpal tunnel syndrome, even pre-existing their injury, is going to get worse. Their symptoms will get worse and may impact their outcome. And then the higher energy injuries, massive swelling. I think that a careful carpal tunnel release is a very appropriate thing to do. With the anatomy being altered, a carpal tunnel release in the setting of a distal radius fracture is a very different surgical procedure than the, simple outpatient 5-minute procedure done under local anesthesia in any situations.
Yeah, I can imagine it's not easy.
These are just some follow-up radiographs after we went back and put in some bone graft and did some fixation.
Yeah, it looks like it healed up there.
He got a little bit of CRPS as well.
All right, so that's a lot. We covered some pretty interesting cases there, and I think some of the important points from those cases that I might replug is that you really want to consider other injuries in the treatment plan and how the patient is going to mobilize and function in their lives. And then not every distal radius fracture needs a volar locking plate, even though it is a useful tool. And you really have to think about how you're going to cater your surgical tactic to both the injury but also the patient. And then obviously antibiotics and debridement and open fractures, and don't miss acute carpal tunnel. Um, any other questions, Phil? No, good to keep the train rolling. All right, this case I think is a nice segue because they have a distal radius and a forearm fracture. So this is a patient who saw me after a high-speed MVC versus a dump truck. And obviously a high energy injury. You can see on the x-rays of the wrist here, you have a distal radius fracture there that is dorsally displaced, and you have a midshaft radius and ulna fracture. And the ulna is pretty close to the skin there. They also have this injury as just an aside. That was a fun one. And this is her injury at the level of the forearm there. You can see a pretty large wound there. Probably getting into that area where you'd say the amount of energy there, though the bone is not super comminuted like Nate's case, but I'd still probably call this a type 3 injury. And so we're going to start thinking about debridement, irrigation, antibiotics, all these factors as we go back to fix this unstable injury.
Hey,
Uh,
Taylor, can
yeah,
I interrupt you? You go back one slide and just put that x-ray up. So, I
yeah.
mean, it's very easy to get lost or just focused in on this both bone forearm fracture. And like some of the bad distal radius x-rays that we showed previously, it's very easy just to get honed in. And at our institution, the radiologist is going to put circles and arrows and everything at the obvious things. And it's not uncommon to miss other things. You know, that distal radius fracture could have easily been missed, even though it's very obvious. But what can be missed even more commonly are phalangeal fractures, carpal bone fractures, scaphoid fractures. So really, you know, making sure that when you're looking at these patients in the emergency room, before you call your senior resident, before you call your staff to save you embarrassment the next day, is that you have done a very thorough evaluation of everything that is included in these pictures.
Yeah, that's a great point. I actually spotted a missed scaphoid fracture the other day. I was pretty proud of myself on that one. I put some money down on that with the residents there. I'm just kidding, but I did get it. So in this case, she has an open injury. She has an unstable injury. We made a plan to take her to the OR to do a thorough debridement and then get it fixed. In this case, I'm not super facile with trying to fix two fractures with one plate. So I used a small mini fragment plate here and then used a longer distal radius plate to treat both the others there. And as we apply that, we try to compress through the plate a little bit given the nature of that fracture. And then on the ulna, we fix that in a similar fashion using compression plating as well. In this case, the things I want to plug here are the importance of getting x-rays above and below. So you can see here I got an x-ray of the elbow, both an AP and a lateral there. This is a fancy view just on the left there that allows us to see if any of our screws are long and at risk for injuring any tendons on the dorsal surface of the radius. And so this is where she is post-operatively. Anyone do anything different in that case? Maybe use two plates instead that are treating the fractures separately or something similar in your practice, Kevin?
Yeah, certainly this requires a lot of preoperative planning to make sure you have everything you need to do these type of cases when you have segmental injuries like this. And if you can get them lined up and you have some of these anatomically contoured plates like you have here on the volar aspect of the wrist, then fixing both fractures with one plate is very adequate. Uh, if you were going to try to fix them separately, certainly reasonable, but you have to make sure that you're overlapping your fixation and not leaving a space of unprotected bone between the ends of these two plates, because that's what we call a stress riser and a higher incidence of fracture right in that clean space that is unprotected. And so if you are going to try to fix this with two different plates, you have to make sure that they're on surfaces of the bone that allow you to place them both without interfering with each other. I really like how you did this here. I think this is very elegant to, you know, with a smaller plate on the radial shaft that you would not rely on by itself to stabilize the radial shaft, just to get some alignment there. So then you could, you know, put everything back together and then stabilize it. I think this is a very nice way to take care of that.
That's very kind of you. Nate, talk to me about why that both bone was unstable.
You know, I think it's when I think about the forearm, I think it's important for me to remember that it's effectively a joint and the radius is rotating around the ulna when you pronate and supinate. And so I like to visualize it as a ring, basically, where the ulna and the radius and then the proximal and distal radial ulnar joints form a ring-like construct. And those have to be restored into anatomic position if you want to have full pronation and supination. And just like any other ring, like a donut, when you break it, frequently it'll break in two spots. And so, you know, the both bone forearm fracture is a great example of that, where you break two parts of the ring, you break the radius and the ulna, but every once in a while, that radius might break, but instead of the ulna breaking, you're gonna see some disruption of the joint, or vice versa. The ulna breaks here in this case, and then we get a dislocation of the proximal radial ulnar joint, or a so-called Montesia fracture that you're showing there. And similarly, the radius can break, and then you can get a disruption of the distal radial ulnar joint for a Galeazzi fracture. And so when I look at an X-ray where I only see one fracture, alarm bells are going off in my head, and I'm thinking I need to be seeking pathology and looking for disease there to see if there's something going on someplace else.
Yeah, that's a great analogy. I mean, I don't know. I don't really break many donuts. I just eat them whole, uh, but certainly you can see a ring being broken in two spots. I use the pretzel analogy personally.
No. Pretzels are too complicated for me. I can't get that many loops in my head.
There you go. Phil, before we dive into a few more cases about forearms, are there any questions just before?
Yeah, they're great ones that are coming in, I think worth discussing. I think one is really pertinent to the X-ray that's currently on the screen. Sam, great question. In the case of both bones, is there a recommendation for sequencing one fracture you fix first to make it less technically challenging? And so we could use this as an example case, but it's variable depending on the injury pattern. I'd say, I don't know, for me, probably 80% of the time the radius gets fixed first, but if the radius is a simple fracture pattern and the ulna is very comminuted, we're going to go to the simple fracture pattern first, generally to ensure that things are out to length. If they're both the same, we'll fix the radius first, at least I do in general, because then you can flex the arm up and things aren't shortening, and it's a little bit easier to fix once the radius, which you fix with the arm out flat on the table, is out to length. So 80% of the time, I'll fix the radius first because it's typically simple enough to fix anatomically to then flex and not shorten and have an easy ulna fix. The one time I won't, dusted radius, simple ulna. We'll go to the ulna first. That can be a somewhat challenging operation just because you're still shortening against the radius. You're going to want to take a lot of time to make sure that ulna anatomy is right. You've reestablished PUDA if you need to. So, anybody else have any
Say
other
that
thoughts
here on
on
the
different styles?
Yeah, I agree with you, Phil.
The other one I'll just bring up, Philip, great question and a great name. He asked about the watershed line of the distal radius and placing your plate to distal and said, are there rules when placing a volar locking plate with relation to the watershed line? And then what are the considerations when you have a severe injury and crossing that line? So what do you think, Kevin, about that question, the watershed line, and then you've got this crazy distal fracture and the plate may cross it. Is that something you'll never do or certain cases or
No,
how do you?
you got to get the fracture fixed appropriately. Now, and that's a pretty high level question and maybe a little bit above the level of this discussion. But you're looking at X-rays, or if you get into the lab and you're doing sawbones and those type of things, you're just seeing these broken bones, and you're ignoring the fact that there's soft tissues that are very intimately associated with these bones. And so, the further distal you place your surgical implant on the volar aspect of the wrist, or if you have not adequately reduced your wrist and so the volar implant is sitting volarly prominent, then you are compromising the flexor tendons. And so watershed, by definition, is an area where there is sort of inferior blood supply, and that corresponds with the flexor tendons right at the that most prominent portion of the radius, volarly, just proximal to the wrist joint. And so if you have an implant that sits prominently there while the tendons are continuing to go back and forth over that area after surgery, you can see attritional ruptures of the tendon. Similarly, you can't ignore the fact that on the back of the wrist, what you're not looking at are extensor tendons and implants that are placed volarly but are sticking through the dorsal cortex and the metaphyseal region of the radius, increases your probability of having an extensor tendon rupture. But in these situations where there are very distal fractures, you got to get the fracture fixed. You have to restore stability and the anatomy. And in those cases, you tell the patients that we're going to have to go back in a couple of months and take the implant out.
Anything else, Phil?
Nope.
All right. So this one, Nate, how would you like somebody to describe this X-ray to you when you're on call so that you can visualize that in your head?
When I'm hearing about an injury like this or describing it, I suppose I would say that this is a mildly comminuted both bone forearm fracture with a simpler ulna fracture.
And it's definitely displaced. and shortened are probably good words to use as well. And so take us through how you fix this one. What was your strategy in this case?
Yeah, in this case, as you might imagine, having trained with Phil, I tend to do things a lot like him, and so I took an approach very similar to him. And we did some lag screw fixation to get some absolute stability of some of these fragments, and then neutralized with a couple of 3-5 locking compression plates on the radius and the ulna. And we
Yeah,
tried to use 4 screws on a side to let this person bear weight.
yeah, that's a great point. So you've lagged and gotten absolute stability and then neutralized some of the torsional forces with that plate there as well. Pretty
Taylor,
straight.
that's a great example. If you go back, this is a great example for the med students to just kind of memorize that in general, the standard of care for implants for forearm fractures are small fragment implants. You know, we've got so many options these days: anatomic, pre-contoured, mini fragment, small fragment, large fragment, dual plates, like you just showed earlier. By and large, I would say probably 90% of the forearms that get fixed at our hospital have a construct that looks like what Nate just produced here. 3.5 millimeter plates, plus minus a lag screw, neutralization plate, plus minus bridging, depending on the comminution. Very standard construct. That being said, it is becoming more and more common in smaller statured individuals, especially for distal third ulnar shaft fractures, to use more mini fragment type of fixation, maybe a 2.7 millimeter dynamic compression plate, just because smaller bones, the 3.5 plates seem to really just engulf, to swallow these bones. They look giant. But by and large, I think most adult males, 3.5 on both plates. You have anything else that you're doing differently?
No, pretty similar. I have put a 2.7, like you said, sort of distally on the ulna there. And they did heal, so but I agree with you.
2.7 may be necessary in the like proximal fourth of the radius as well.
That's a great point. Great point.
So this one's a bit different. Take me through this one and talk to me about how it's different and which of those other names is it?
Yeah, so this is that Galeazzi fracture that we talked about earlier. And again, you know, maybe on this first X-ray that you look at on the left, if you're not looking carefully, you might see that radius fracture and not really notice much else. And I think it's important to remember that there are other injuries present in these situations quite often. And this other view, of course, makes it very obvious that distal radial ulnar joint is dislocated, making it a Galeazzi fracture. And so when we're treating this, you know, the first thing we want to do is get that fracture anatomic. And the hope is that we can get, by doing that, a good reduction of the distal radial ulnar joint. And if it's not well reduced, we need to reassess our reduction and assume that the reduction is wrong. And that's the reason that that's not reduced. And then the distal radial ulnar joint may be stable or not. And in this case, that distal radial ulnar joint was not stable. And so I elected to treat that instability by pinning that joint percutaneously and leaving those pins in for 6 weeks before removing them. And then at her 6-week follow-up visit, she was able to get those out. And in final follow-up, she's moving well.
And so how do you decide that that ulnar head is unstable there, or that DRUJ is unstable?
Yeah, so I like to compress the DRUJ and then take the forearm through pronation and supination and feel if I can feel that ulnar, that DRUJ subluxating, basically.
And do you test the other side to compare ever?
I think it's nice if you're trying to do a shuck test that some people talk about, where you grab that ulnar head and try to wiggle it back and forth. There's a lot of variability in that. And of course, that also varies based on the forearm position, whether you're in supination or pronation or neutral. And so having a good comparison for that individual can be helpful as well.
How do you like to test it, Kevin?
Well, I think, you know, the other side, if uninjured, is always a great template, right? I do test after every distal radius fracture, after every forearm fracture, just sort of the shuck test that Nathaniel mentioned, where you're going to sort of hold the radius stable and then try to bring the ulna volarly and dorsally. And the DRUJ is always a little less stable in neutral rotation and should stabilize in supination as well as pronation. And I tend to immobilize all of my wrist and forearm fractures in supination after surgery. But if it is grossly unstable, if it's stable in supination and unstable in pronation, you put them in supination for a couple of weeks, they end up doing mostly very well. But if it's grossly unstable in all positions, and if you can't get it reduced, you got to make sure as was mentioned, make sure your radius in this situation is anatomically aligned. There can be soft tissues interposed between the radius and the ulna distally, so making sure that there's not soft tissue interposed. And then if it's still grossly unstable, then you got to do something. And so whether it's transarticular fixation, I would tend to use my K-wires a little bit more proximal than this and not put a wire through the distal radial ulnar joint itself. You want to make sure you're using big caliber wires so that they don't bend, because even in a cast, there's a lot of force across those wires, and a wire that bends can be a pain to remove, or if it breaks. And also making sure that those wires are going through 4 cortices, so that if it does break in the interosseous space, you can still remove them from both the radial and ulnar aspect. But this patient also has an ulnar styloid fracture. And so it may be that fixation of the ulnar styloid or repair of the TFCC gives you the stability you need to avoid the pinning. So it's very uncommon that I'm using K-wires, but in some situations it's very appropriate.
Yeah, I think that's probably one of those differences between trauma surgeons and hand surgeons. They just have that different knowledge base where they can do those things. I think I'm probably more in this camp as well, where I'm pinning it if I need to, because I haven't done the other things really. But that's what's valuable about coming together like this. So there you go. Shoddy's all healed and doing well. So then this last one, if you take us through this one really quick, Nate, this one is got to be the other eponym that you showed, the Montasia then, right?
Yeah, that's right. And so again, ulna fracture, but not just an ulna fracture. And if we look carefully at the elbow, we see in this Montasia fracture that the proximal radial ulnar joint is dislocated here. And if we scrutinize carefully, it turns out there's actually a radial head fracture there as well. So a little bit of a cheat here, but.
Yeah, and I think maybe another sign of something that you want to make sure you are on top of when you see patients with these injuries, that you're getting all the jewelry off those extremities. Here, this one is one of the injury films. You go see that patient, you're going to get that bracelet off pretty promptly for sure.
And so in this case, we fixed the ulna and then we assessed the elbow, and we felt like that was a little unstable still. And so we went ahead and went after that radius fracture as well and fixed that too.
Great. And in this case, how do you decide that the radius needs to be fixed versus making sure your ulna is good? I mean, it looks like you probably got it anatomic because you got those lag screws there. So
Yeah, I spent some time on my ulna to make sure that it was right. And when I thought the elbow wasn't stable, I checked it again. And only when I convinced myself then did I move on.
perfect. Yeah, I think it's really important to continue to scrutinize those things as you go through. And it looks like the patient healed well here. The radial head's reduced. So that was a lot to get through for sure. We're going to summarize real quickly from all that stuff we went through, that you will really want that systematic history and physical exam and a really thorough neurovascular exam, like Phil talked about, maybe kind of targeting that to what you know is at risk. And then that really low-hanging fruit about the carpal tunnel, and then thinking about how you're going to approach these injuries and do your closed reductions in the ER, because these are common. You're going to see a lot of them. You're going to do a lot of these reductions. And then as we talk about closed versus open reduction and internal fixation, thinking about LaFontaine criteria as well as other patient factors. And then with regard to both bones, these are joints like Nate described. And so restoring stability to that joint is important. Any last questions, Phil? No, perfect. We answered them all. You guys were so good. You had just such good guests here, so that we answered them all along the way, and everybody's gonna manage their distal radius and forearms perfectly now. Next month, we're going to talk about fractures about the shoulder girdle. And we've got a girdle surgeon joining us to talk about those things. And so that's what he told me. That's what Augie told me. He's a girdle surgeon. And so this is one of the cases that we'll talk about, and they'll bring some more cases. And so it's going to be a good discussion about proximal humerus fractures, maybe some scapulas, a little bit high level there, but just getting a sense of some of those other areas of the body that we didn't touch on last year. Otherwise, thanks so much for joining us. We won't take you any more of your time. Kevin, go turn that TV on and get that score real quick. Otherwise, thanks so much for joining us, guys. Really, thank you so much for sharing your expertise. Don't forget to claim your badges and watch on YouTube later. That's that. Thanks so much, guys.